insulin resistance is a phenomenon with two facets that you cannot pull apart. The expected reduced signaling, where the hormone insulin isn't quite working the way it used to throughout the entire body. Now, that is not a universal effect. It's not that every cell of the body isn't responding to insulin anymore, but some cells aren't responding as well. So I'm just kind of couching that in a vague, insulin isn't working as well as it used to. So that's the insulin resistance part. And that's a cell-specific phenomenon. But of course, these cells are within the entire body, the entire organism. And within the entire body, we have another aspect to this, which is hyperinsulinemia, so the elevated insulin. That is what is so important. There is no such thing as insulin resistance without there being an accompanying, and I would say often preceding, hyperinsulinemia. But if you're following an individual over their life, our metabolic view is very glucose-centric. And I don't even mean to imply that it's wrong. For example, I'm an enormous advocate, and I know this is an advocacy you and I share with regards to the clinical utility of CGMs. And being able to constantly monitor glucose is a powerful tool because it's the dynamic nature of glucose that helps you get a better insight into your metabolic health rather than just a fasting glucose test. The average individual who's coming to their physician year in and year out, they will be gaining weight. They will have high blood pressure. Now they're on an antihypertensive medication. They may have some form of infertility in male or female. And the physician is only ever looking at the glucose levels. And because the glucose levels are staying in a decent range, they assume, well, there's no metabolic problem here. But if we truly want to understand metabolic problems, we have to look at the hormone insulin, because the glucose levels are themselves simply a symptom or a manifestation of disordered insulin action. And so here's
it's not part of a standard comprehensive metabolic panel. So this is a discussion we were having in our medical education. And even the students are kind of like very confused by that. So
we have conventionally trained clinicians who just are really taught to look at glucose. But if they were to include an insulin measurement, they would have found that over the years, insulin has been getting higher and higher and higher. And this is reflective of insulin resistance, but it's enough insulin to keep the glucose in check. It's when there are now an additional handful of events, which includes the insulin resistance progresses to tissues like the alpha cells of the pancreas that release glucagon, and it progresses to the liver becomes insulin resistant, and now we have dysregulated glycogenesis versus glycogenolysis and gluconeogenesis. And then even the muscle, which is of course the main consumer. About 80% of the postprandial glucose clearance when someone eats a starchy, sugary meal, it goes into the muscle. But then as the muscle becomes insulin resistant, its ability to pull in glucose is reduced by about 50%. So it goes down by half. And in some people, it stays there. It's making 10 times more insulin at any moment, the beta cells. And then in some instances, it comes down, but it never bottoms out. Not in type 2. That does not happen in type 2 diabetes. But suffice it to say, if we combine all of these variables, the insulin resistance at the glucose managing tissues and tendency to produce less insulin, now we have the glucose starting to change and potentially changing quite rapidly. And then it's only at that point within this glucose-centric paradigm that conventional clinical care will detect the problem. And now the clinical focus will include a conversation about, well, we got to control your diabetes. We got to control your blood sugar levels. But even still, Dom, as much as the focus will have now included a metabolic component to it, conventional training wouldn't have shown what is so obvious to many of us, that is that this patient's preceding health problems, the hypertension, maybe the migraine headaches, maybe the infertility, are all to varying degrees impacted, if not directly caused, by this insulin resistance that has been lingering in the background for potentially decades, before the glucose ever starts to climb.
But I was just like super engaged by the presentation of the chronological, what you just really nicely explained. Is there human data? My colleague, Dr. Barbara Hansen, who's worked along with like Gerald Schulman and others, like really one of the leaders in understanding like insulin physiology.
I adopted and adapted it from a publication from you might have met him, and I bet people have heard of him. He's a pediatric endocrinologist, and his name is Jake Kushner. I'll try to find that manuscript so that we can include. So he had put together a figure one time in one of his review articles that he published a few years ago, and it showed that paradigm. And that's why I felt so confident, especially Dom, especially on the early part of it. I don't think would be controversial at all, that insulin's climbing before the glucose starts to climb. And then it was this idea that even if the insulin starts to come down, in type 2 diabetes, it does not go to zero.
There's an age-dependent decrease in insulin, associated with type 2 diabetes, which could lead to like insulin-dependent type 2 diabetes. But it's that you may have not kind of captured. Maybe it's more like early age and middle age, but in advanced age, I think in non-human primates, insulin starts to tank later on. And it could be a consequence of just what you've been talking about, which is another consequence of insulin resistance is just beta cell burnout.
I'd say it was about in the 60s, within the decade of people being in their 60s. But interestingly, even then, when beta cell number starts to go down, there are human studies to show that with dietary intervention, but they found in type 2 diabetics, even as beta cell mass starts to go down, which I would say is not a bad thing. After all, beta cell mass expanded significantly during these decades of hyperinsulinemia. I actually do not consider that to be the problem that many do. If anything, it's putting them back closer to where they used to be. And I think there's an opportunity there because in conventional clinical care, insulin's been coming up, they're insulin resistant, insulin may start to go down, and then the glucose levels start to go up. Because the conventional model is only looking at the glucose, that view then justifies pushing the insulin up even higher and giving the type 2 diabetic insulin therapy. That increases the descent. They will start to gain weight much more rapidly. Their metabolic rate slows significantly. It's something people don't appreciate, that insulin slows metabolic rate, and that, of course, amplifies weight gain, and they become more and more insulin resistant. With all of that insulin, which is so pathogenic, they're 3 times more likely to die from heart disease. Yes, there are instances through human development where we call an insulin resistance physiological rather than pathological. All of the insulin resistance you and I have been discussing up until this point is pathological insulin resistance. Physiological insulin resistance is a state when the body becomes insulin resistant to serve a purpose. And that purpose is always and invariably to promote growth. Because if you can create an insulin resistant profile or phenotype, all of that insulin and its selective insulin resistance, but remember, it's still insulin sensitive at other tissues, it collectively creates a body that is promoting more anabolism, more growth. And that is utterly essential to the 2 Ps of physiological insulin resistance, pregnancy and puberty. During both of those instances, all accompanied by hyperinsulinemia, because there's no such thing as insulin resistance without hyperinsulinemia. Even in physiological, those bodies, whether it's mother's body trying to grow fat or develop mammary tissue or grow a placenta, even the fetus benefiting from this, or whether it's the young preteen adolescent who needs to go through the most dramatic period of growth in their life, regardless, both of those are instances of massive, rapid growth, and a generally insulin-resistant body facilitates that. And again, it is not harmful. There are times when I describe the insulin resistance of pregnancy, and I'll have someone say, well, how can I mitigate that? And I say, you don't want to mitigate it. Well, you couldn't if you tried. It would be utterly incompatible with the pregnancy if you blocked it. But of course, we don't want it to go too far. Otherwise, the gal shifts over from physiological insulin resistance of pregnancy into gestational diabetes, of course, which is, again, that same state I outlined before. In a healthy pregnant woman, her glucose levels are normal, but her insulin levels are elevated, reflecting insulin resistance. And then if she becomes so resistant to insulin, I would say largely due to a combination of genetics and dietary influence. Now she's so resistant to her insulin that she can't control her glucose anymore. Now we say she has gestational diabetes. So yeah, a resounding yes. There are instances of physiological insulin resistance, but a low carb or ketogenic state is not one of them. Remember, because some tissues still respond sensitively to insulin. And in that case, like for example, bone, to my knowledge, bone does not become insulin resistant in the adolescent. And indeed, all that hyperinsulinemia can promote greater bone growth, and the hyperinsulinemia can defend protein synthesis. There was actually a study from the 80s finding that insulin, rather than promoting muscle protein synthesis, it appeared that its main mechanism of action was defending or inhibiting proteolysis, so defending muscle protein. If we took a healthy individual who had a healthy fat mass, because that's so important to all of this, their insulin levels as a child would be in a healthy range, kind of maybe around 10. And then in that range, 10 microunits, in the span you just mentioned, in the kind of mid-teens, like right when growth is peaked and peaking and then about to come down, I would expect insulin levels should normally be in the mid to high teens. And then after that, they have grown, they're done making fat cells for the most part. And then they've reached adulthood, insulin levels will come down and then should settle back down to under 10. So it can almost double during puberty and then it should come back down. There was a fascinating study in young women with polycystic ovary syndrome who did not meet any obvious clinical metric of insulin resistance. But then the scientists, in other words, they were generally normal body weight, they didn't have dramatically elevated fasting insulin, or their HOMA score was normal. But when they measured the insulin and the free fatty acids and computed them together, they were significantly higher. That overall formula was significantly higher than in their equally body weight control group. So same body type, same body mass, and yet no PCOS in those women, their adipose IR score was significantly lower. And I think that's further evidence that this is a problem that starts in the fat cells, even if it hasn't manifested throughout the rest of the body. Once the fat cells become insulin resistant, it's the first domino to fall, and then it's just a matter of time before it starts tipping over into other tissues. Triglycerides are one of the fastest responders to carbohydrate restriction. So triglycerides will just plummet dramatically. I actually consider triglycerides to be perhaps the single best lipid marker of heart disease. As much as we have focused on LDL for now decades, I consider that to be very unfortunate, because LDL is a terrible predictor of heart attack and heart disease risk. And I think triglycerides is a better marker. Now, the question is, well, why not look at triglycerides? This is a bit of a cynical take, Dom, and you'll pardon me for expressing it. I think one of the reasons we don't measure triglycerides more often is because we don't have a drug that can specifically target triglycerides like we do with, say, LDL. But even then, reflective of insulin's almost dictatorial ability to control fuel metabolism, nutrient metabolism within the whole body, insulin controls not only the measure of free fatty acids through lipolysis, but insulin also controls lipogenesis, the formation of new fat. And when we look at how insulin stimulates lipogenesis in the liver, promoting the synthesis of triglycerides, and then packaging those triglycerides into the triglyceride-rich lipoproteins of VLDL and LDL, the main transporters of triglycerides through the plasma, it's no surprise that insulin will dramatically increase triglycerides. And that, I believe, is maybe the most relevant variable with regards to heart disease risk, or at least the best predictor. When insulin starts to come down through fasting and lifestyle interventions, triglycerides will come down very rapidly as well. And some of the extent to which this can happen is truly mind-boggling. I saw an exchange between David Unwin, that kind of English gentleman physician that we all know and love. He was one time jokingly bragging about how he had a patient whose triglyceride levels went from something like 800 in the course of just 8 or so weeks down to like 60. And just these fantastic reductions, all because when insulin, but mind you, Dom, this is in the midst of the person possibly eating more fat than they've ever been eating.
Yeah.
It's just because it's not, triglycerides in the body are not a reflection of what fat is being consumed, but rather what fat is being produced. It's what's coming from the liver, and insulin will push that. Insulin will dictate that. I have not been able to find a single instance of a cell that does not have an insulin receptor. In other words, everything I've seen shows that literally every cell of the body, including red blood cells who, don't even have a mitochondria, they don't have GLUT4 of the glucose transporters, but even still, they have, of course, GLUT4 expression doesn't have anything to do with it, but they all have insulin receptors. So a lot of these individuals who study longevity and generally promote a low protein diet, they do so, if I may put words in their mouth, and that might not be fair. I believe they do so because it's their view that dietary protein will stimulate mTOR in the body, in cells. And if mTOR is activated, that will inhibit autophagy. And then now you're promoting cellular aging. That is certainly the justification for the use of rapamycin, which is a very strong mTOR inhibitor. So that's the idea, that it sort of centralizes on that enzyme, the protein in the body, in the cell, that protein mTOR, that if they can turn down mTOR, now they disinhibit autophagy, and then longevity would be promoted. That is, of course, all based in animal studies. There's no, even these individuals would admit there's no conclusive human evidence. If the primary goal is to inhibit mTOR or keep it turned down more often than it's turned on, all the more reason to scrutinize the hormone insulin rather than amino acids. A study done in muscle cells found that leucine, the most anabolic mTOR stimulating of all the amino acids, it did activate mTOR, but it did not activate it as much as insulin did. Insulin stimulated mTOR much more dramatically than leucine did. And I think that, to me, neither of those is inherently bad. But if lowering mTOR is the primary outcome, all the more reason to focus on insulin. Because, Dom, we both know it's the average individual who is living every waking moment in a state of elevated insulin, not constantly elevated, leucine or amino acid. And that's because we wake up in the morning, insulin has come down throughout the night. We spike it with a starchy, sugary breakfast. We do it again with a mid-morning snack, again at lunch, again in the afternoon, again at evening, etc. Every waking moment is spent in a state of elevated insulin. That is the problem. If the worry is that mTOR is too constantly activated, it's not because of dietary protein, because most people don't eat a lot of protein.
Yeah. I
am unabashedly an advocate of animal proteins simply because of the assurance that you're going to get everything you need. There's no need to worry, am I getting the right mix of amino acids? The moment you go to plant-sourced proteins, you do have to ask, am I getting everything? Now, Stuart Phillips, who is kind of the expert on muscle protein synthesis, he has found that if you just go to the base amino acids from plants and animals and load a human with those, their ability to promote muscle protein synthesis is equal. So there's nothing inherently problematic about the amino acids from a plant. It's just, are you going to get all of the proper mix of amino acids? And are you getting it in the kind of cleanest, most absorbable form? And you noted it has been confirmed that some plant-sourced protein supplements are very high in metals, and they can be elevated. They can have higher levels of oxalates and phytic acids, molecules that actually inhibit amino acid absorption. So my thoughts on animal protein are that if a person is primarily relying on plant protein, if a person's primarily relying on plant protein for their dietary protein, then they should make an attempt to consume it the way our ancestors would have, depending on who our ancestors are. But like, for example, throughout Asia, a culture that has been relying on plant protein in the form of soy for, since time immemorial, or even instances of communities in South America, they would ferment the plant protein. And so and we know that fermentation enhances absorption, in part because it removes some of these absorption inhibiting molecules like oxalates and phytic acids. In fact, it's appropriate that you mention fats, because my view on animal protein is that I believe it should come with fat. We know that in humans, if you give a human a load of protein, even like among the best, like egg white, and then you measure the amino acid uptake and muscle protein synthesis as a result of that, it will be significant, of course. But if you couple that protein with fat, we absorb the protein better, and we have greater muscle protein synthesis. But part of the reason we absorb it better is through the actions of bile. The bile acids in the stomach, in the intestines, we always look at bile as only being relevant to fatty acid, or rather lipid digestion and then subsequent absorption, because it will, separate all the fat out. It's through the gut, emulsify it, just to enable all the enzymes to get at the lipid better. But we also, bile acids also accelerate and facilitate proteolytic enzymes in the intestines as well. This is why when I hear someone who says, well, I can't take whey, and whey protein is like maybe the single best protein source for humans. But they'll say, I can't have a whey-based shake, it upsets my stomach. And the number of times I have seen this happen is so much, the anecdotes just keep stacking, where I will say, well, what if you mix a little bit of fat in there, either a little bit of, warmed butter or a little bit of cream, then how? And they will try this, and sure enough, their digestion problem is resolved. It's because in nature, I don't think there's an exception to this. I'm unaware of one. In nature, there is no such thing as a protein that does not come with fat. That, I think you've touched on something that I have almost laughed at sometimes, which is our obsession with chicken. Because 100 years ago, we didn't eat chicken. Chicken was a fantastically, Christopher Ramsden at the NIH has done his best to kind of quantify what is the consumption, what are the eating patterns with regards to meat and the fats that come from those meats. And chicken was this minuscule part of the meat that we used to eat. And now it has become the single most commonly consumed meat, all because it's so low fat. We used to keep our chickens around for their eggs. And then it was this kind of fear of fat that drove us to eat more chicken meat. But you're right, turkeys, we never kept turkeys around for the eggs, we ate them. So
they've been hunted forever. Yeah, we got wild turkeys running around. And I mean, there's a big push to switch from beef to chicken. And I mean, we go to chicken like fairs and things like that, and it's like the amount of hybridization and odd forms of chicken. I mean, it's just like a whole breeding experiment in progress, to build bigger breasted birds and birds that can barely walk. And I mean, we see it, in our farming community here. But
any meat is going to be good. And generally you're going to get all the amino acids you want. But I put chicken at the bottom, that I would put any meat, I believe, is a superior source of ultimate and like more complete nutrition is going to be better than chicken. So which is frustrating, because of course chicken's so easy to eat. Like as a dad, my kids want chicken more than anything. And I'm always trying to like insert some kind of beef, especially for my girls. I want them to get that iron. But even still, I would stack any meat as being better than chicken, but I'm also fine with chicken. I would just say maybe make sure that it's not too lean, because fat helps the digestion of the protein.
That's, I teach the whole GI section and really have to revisit it. The bile acids do facilitate, protein digestion, things like that. I mean, I usually talk about, I tend to I do the opposite of what you're supposed to do. Some days I undereat during the day and grossly overeat at night. And if I don't do that, I lose weight. So I know, eating less at night or shifting more is supposed to be better by all metrics. And if you eat at night, you're more likely to gain weight. But for me, that's a positive thing, because if I don't eat at night, my weight slips and I start to lose actually muscle.
You're right to note that in the human studies, people who have an earlier eating window appear to be more metabolically, it's more metabolically beneficial. So eating, for example, breakfast and lunch appears to be better than lunch and dinner. I have a family, and I don't want to be sitting around dinner with my family. Like last night, we're all eating. And if I'm just sitting there looking at my wife and kids while they're eating, because I'm fasting through dinner, no, forget about it. I'm a family man, and eating dinner is a very important social moment. So I'm not going to do that. But what I have found, I have found that the single most important variable that will determine whether I sleep well or not is how full I am when I go to bed. More than anything else, more than light exposure, more than any kind of activity. If I go to bed on a really full stomach, I will be hot. My HRV will be low. I will not sleep well. And I'm wake up and I'm miserable the next day. You know, someone can be gaining fat mass through two different mechanisms. It can either be that the number of fat cells is relatively static, but the size of the fat cells getting ever larger, hypertrophy, or in some people, largely due to a genetic tendency to go one way or the other, but this is a minority of people. There are individuals who even throughout adulthood have the genetic potential to continue to make new fat cells. And that's getting fat through a process called hyperplasia. And in that case, the fat cells stay very modestly sized, but they're, of course, just much more abundant. Well, that person paradoxically has then almost limitless potential to store fat. These are the people who get fat through hyperplasia, who can become fantastically obese, 500 pounds, 600 pounds, and they don't become insulin resistant, and their insulin levels stay quite modest. However, on the other side, where the majority of people fall, their number of fat cells is set. So if the fat cells are storing more and more energy in them due to an abundance of energy and elevated insulin, that's important though. Those two signals are both essential to promoting fat storage. You need abundant energy and elevated insulin. In the absence of one or the other, they cannot get fat. You can eat all the energy in the world, and if insulin is down, you cannot store it as fat. You'll be wasting it as ketones. Your metabolic rate will be higher. If it gets too high, then you'll even be peeing out glucose. You cannot store energy as fat if insulin is low. So it is the hypertrophic fat cell that becomes insulin resistant in order to prevent further growth. That's why free fatty acids start to go up. It's the hypertrophic fat cell that becomes pro-inflammatory in order to correct hypoxia and stimulate new capillary growth to those hypertrophic fat cells. So some of those inflammatory cytokines will promote new vascular growth. Some are just promoting inflammation and stimulating insulin resistance. So the strategy has to be to take that big hypertrophic fat cell and shrink it. And you can shrink it through two different ways: low energy and low insulin, or low insulin. They're not the same, although one, they tend to bleed into each other. If someone takes their first weight loss journey or fat cell shrinking step, and it's with a low energy approach, usually they're going to start fighting hunger. If energy is coming down and they're still insulin resistant, then as they just start cutting back energy, then the availability of energy in the blood will start to drop a little bit because insulin's still high enough in them. And it's going to be hard to shrink the fat cell. They're going to get hungrier and hungrier, and usually hunger wins. So rather than take a low energy approach for the first step, my recommendation is to shrink fat cells, take the low insulin step. And the low insulin step is kind of what we've been alluding to, which is, control your carbohydrates. Don't get starches and sugars that come from bags and boxes with barcodes. Focus on whole fruits and vegetables. You eat them, don't drink them. Prioritize protein, don't fear fat. But if you're hungry, eat. There is no hunger that has to come into this. And so it becomes much more sustainable. And as insulin is down, free lipolysis is activated, and the person's mobilizing fat more. They're burning fat more. They're converting it to ketones, which they use for energy. And they are just dumping from the body in the form of in the breath and in the urine. The ketones are energetic molecules that are just wasted. They don't have to be burned or stored.